Kalimera. Unfortunately, this is the only word I know in your great language. Dr. Kuratas, thank you for the invitation. It's a great pleasure for me to participate to this meeting and give this keynote lecture. Let me introduce myself. My name is Professor David Khayat. I've been head of the Department of Medical Oncology at the Pitié-Salpêtrière Hospital in Paris for almost 30 years, and I've been the former president of the French National Cancer Institute. And between 2002 and 2006, I was the advisor of the yet president of France, Mr. Jacques Chirac. Before I start, I would like to show you my conflict of interest. I am working for many companies working on food processing and also specifically on harm reduction with Philip Morris. So the question you have asked me to answer is a tough question. Could the scientific and medical community play a role in making policymakers to reconsider the tobacco control strategy? I've been thinking a lot about that question, and I think that it is not the right question. The right question shouldn't be could, but should be should. Why? Because as doctors, we have no choice. These people are our patients, and we have to take care of them. If you look at the past and even the present, all the policymakers have been guided by people who have never seen a real patient. We have never really taken care of these suffering human beings affected by cancer or cardiovascular diseases due to tobacco. There are more epidemiologists than real clinicians. So if we want to improve the situation in the future, we have to empower doctors. Why? For two very simple reasons. Doctors are the only population that know the science beyond everything and who are caring for the patients. And these two things are really very important. What is the situation today in the field of tobacco control? Everything is based on an international convention, a global convention that has been signed in 2005 by more than 180 countries, which says we have to eradicate smoking, not considering any acceptability, any possibility that this would not be achievable, just eradicate smoking. And for doing that, forbidden to talk and to exchange any information with the tobacco industry. What does tobacco control mean for smokers? These are the future patients. These are the people that are being threatened by tobacco. You can summarize what does that mean for them by a very simple sentence: quit or die. Either you quit smoking and you are a good guy, or you don't quit smoking and we don't care of you. You can die. This is your fault. But as a doctor, I cannot accept this sentence for my patients. We can have a look at the evolution of the situation in the tobacco control policy field and ask three questions. Is this accepted everywhere? What other options are there? And what do we see in other countries? So for the first question, the answer is no, not anymore. Many countries have changed their position, although they have been signing this global treaty. The second question, are there other options? Yes, there are other options today due to the innovation, like snus, like e-cigarettes, or like heated tobacco. And what do we see in other countries? You can see that in the darkest part, these are the countries where you have the smallest number of cigarette smoke. And if you see and try to understand what is in common with these countries, which include Sweden, Norway, Iceland, for instance, or UK even, is that they have accepted innovation. Some of these countries, the countries like Sweden, Norway, and Iceland, have accepted snus, which is an oral tobacco that delivers nicotine without having any combustion, or in UK, they have accepted and allowed the use of e-cigarette. When we talk about smoking, what is the real issue in smoking? It's cancer, because cancer is a major public health issue. According to WHO, there is still more than 1 billion people in the world that are smoking. And this leads to about 8 million deaths annually worldwide. Out of it, 1.6 million are dying from cancer. So there is obviously a kind of relative failure of all the tobacco control policies. What do we know now if we want to change the situation? We have to know what is a cancer, what are the risk factors for having a cancer, and how combustible cigarette smoke can cause cancer. So, very simple definition of a cancer. Cancer is an unlimited and uncontrolled proliferation of mutated cells. And these unrepaired mutations are usually related to the effect of an exposure to a carcinogen. If we look at the second question, what are the risk factors? We can see what were the risk factors in 1990 and what are today the ongoing risk factors in 2017. It's the global numbers. You can see that about 27 years ago, the first cause of cancer was smoking. Obviously, this is behavior, attitude. I mean, it's not due to a disease or it's not due to a genetic abnormality. It's due to the fact that people are smoking. It's a behavior issue. For 27 years, we have been trying to change these behaviors. But if you look at what are in 2017 the first cause of cancer, you can see that it is still smoking. So what does that mean? That means that whatever the tobacco control policies that have been using in the last 30 years, smoking was and still remains the first cause of cancer. So it's a total failure of this strategy. We have to find another strategy. Now, we said that the mutation in these cancer cells are due to carcinogens. What are the carcinogens and how does it work when we talk about tobacco and cancer? Actually, you have to understand something that is very important. In the field of cancer, in that disease, it's always a carcinogen that's going to induce the mutation and therefore induce the cancer. These carcinogens can be found in the food, in the water, in the air. That can be a physical factor such as irradiation, for instance. That can be also some infectious disease, for instance, like HPV. But whatever the carcinogens and whatever its nature, there is always a dose-response relationship between the exposure to a carcinogen and the risk of having a cancer. More you are exposed to a carcinogen, higher the risk for you to develop a cancer. And that idea of dose response can be either the dose of carcinogen, like smoking 1 cigarette or smoking 20 cigarettes, is not exactly the same risk. And it's the same for eating processed meat, eating just 20 grams per week of processed meat or eating 100 grams of processed meat per week, you will not induce the same risk of colorectal cancer. It can be also the duration. In that slide, for instance, you can see that whenever you smoke 1 pack a day or 2 pack or 3 pack, the longer the exposure to that carcinogenic effect of tobacco smoking, higher your risk of having lung cancer. But how does cigarette smoke can cause cancer? It is well established today, and these slides show you, we know that if you burn tobacco leaves, you will generate a smoke. And that tobacco smoke will contain a lot of chemical and ultrafine particles, more than 6,000. Out of this huge number of molecules, you will find about 93 molecules that are considered as harmful or potentially harmful constituents. The majority, about 80 of them, are real carcinogen or potential carcinogen. This is what is causing cancer in the tobacco smoke. How this carcinogen can appear in the smoke due to the combustion of tobacco leaves? Well, in that slide, you can see that it is a question of temperature. As long as you heat the tobacco leaves, the tobacco, at less than 350 centigrade, you will almost not generate any of these carcinogens. But when you get a temperature higher than that, here you are not just heating, you are burning the leaves, and the tobacco can start to produce a black smoke, and that smoke will contain all those carcinogens that you can see in that slide, including benzoapyrene or many other of them. If we want to change the strategy and move from the idea of quit or die, we have to consider another strategy, which I think is more important and most probably much more efficient for our patients or future patients. And this is what we call harm reduction. Harm reduction started in the 80s when in the UK, Mrs. Thatcher, at that time Prime Minister, decided to try to avoid IV drug users to get beside the side effect of the drug use. these diseases such as HIV or hepatitis. And for that, they propose to those who cannot quit the IV drug addiction to get some clean needles, clean syringes, and safe havens. And thanks to that, the number of people having HIV within that population in UK decreased very, very significantly. Unfortunately, about 10, 12 years ago, a new think tank has produced a new policy in the UK, which instead of trying to help people to avoid the harm of their addiction, to say back to abstinence-based policy. What happened then? Well, during the last 10 years, drug-related fatalities in the UK have doubled, and 1 in 3 drug-related deaths in Europe are in the UK. So it is, again, a total failure of this abstinence-based policy. So based on that, you can imagine a strategy which say, we try to change the behavior. We try to help people to quit their addiction, smoking, drug, whatever. But if they cannot quit, we have to help them to be prevented from the harms of their addiction. And this can work for many things, for diet, for instance. Okay, try to do some good, to have a good diet. But we know that even people with diabetes will continue to overeat. But we can give them statin, we can give them anti-diabetic drugs. And for people driving too fast, we can have seat belts and disc brakes and airbags. And innovation can provide the possibility in many fields that are related to your health to get a kind of prevention for the consequences and the harms. Actually, this is very important to understand. It's not just tobacco. Everything in life can be a poison. This is Paracels a lot of years ago has stated that, but it is still true. Going to the sun for 5 minutes or for 3 hours, drinking 1 glass of wine or drinking a bottle of wine, everything can be dangerous if you cannot control the exposure to carcinogen, and because of that, maybe sick and may get a cancer. Well, what does that mean at the population level? Well, if you look at that slide, you can see that in the world, the number of cancer, which is the second cause of death globally, is increasing every day. And this is a real threat because cancer is still an incurable disease in many cases and costs a lot of money for our economies, and is usually in developed countries the first cause of premature death. But if you look at the current global trends in current tobacco in adults, you can see that the number seems to decrease. Oh, so you can be very happy with these numbers and say, you know, we've got it. But unfortunately, these figures are just totally impersonal, and they don't the whole story. If you want to see what is the whole story, see the next slide, where you can see that whatever the country, whatever the continent, the number of smokers, which means the number of people exposed to the risk of cancer because of the tobacco smoke in the combustible cigarettes, is absolutely flat, and there is no decrease. And that is important because this is exactly what we want to avoid. So the next point is, can innovation in harm reduction save lives? And this is very important because this is at the end of the day what we want, saving lives, the lives of our patients. And we can see that innovation can do that. If we look at the situation in Sweden, where they had the possibility to switch from cigarette smoking to snus, they have had a huge decrease in the number of people smoking, and therefore also peak and decrease, as you can see in that slide, in the tobacco-based mortality in Sweden. My question then is, as a doctor, and it comes to the answer to your question, how can we accept as doctors that this innovation will not be available everywhere and to all citizens? Between 2002 and 2006, I was the advisor of Jacques Chirac, former president of France, and at that time I was in charge of the National Cancer Control Plan. What I did in my struggle against tobacco smoking is that I increased the cost of a packet of cigarettes from 3 to 4 and 4 to 5 euros within less than 2 years. We had 1.8 million less smokers. Great. It was a great achievement. Actually, the number of sticks, of cigarette sticks that were sold in my country at that time went down from 80 billion a year down to 55 billion a year. So we can be very happy with this number, but again, it doesn't tell you the truth. The truth is that after 2 or 3 years, unfortunately, this patient went back to smoking. Being aware of that kind of issue with some good friends in 1999, just before the millennium, we decided to write a charter to try to raise awareness everywhere in the world in the huge and urgent need to fight cancer with appropriate methods. So we decided to write that charter. We have here the preamble of the charter that you can see in that slide. And finally, the 4th of February 2000, at the Élysée Palace, which is the kind of White House for France, Jacques Chirac, former president of France, and Dr. Matsuura, at that time General Director of UNESCO, have accepted to sign that charter and to launch it. It is very important because this is one of the first real endeavor, global, totally international, where all the doctors, the researchers, all the stakeholders in the fight against cancer can commit themselves in trying to improve the situation and the outcome. The first article of that charter is maybe the most important one, is that cancer patient rights are human rights. We have to try to avoid them to die by any means we can. So indeed, we have been trying, and we still are trying to convince them to quit tobacco because this is the best option. But if you look at people that have been diagnosed with lung cancer because they were smoking and you tell them to quit, you can see that, unfortunately, more than 60% of them will not be able to quit and will continue to smoke, although they are suffering from a very severe and lethal cancer. So, is harm reduction ethical for a doctor? In theory, we can imagine that we'll be able to change the behavior of everybody. But in reality, I showed you it's impossible. It doesn't work. So where are these evidence coming from? They are coming from studies that have been done on compliant patients. But non-compliant, the 64%, for instance, of lung cancer patients that do not want to quit, they are not controlled by any clinical study to see if we can really help them. So harm reduction is a strategy that acknowledges the patient's value as a strength rather than not a weakness. And it accepts people's freedom to choose an healthy behavior, but try to prevent them from the harm of them through innovation. As doctors, we must focus on providing to our patient or future patient with the best care. My conclusion is that doctor is in the middle of very heavy and meaningful situation between life and death, sympathy and empathy, hope, sufferance. And as a doctor, it is not a question of could, but a matter of should. As a doctor, we owe it to our patient. It is, to my point of view, and this is my conclusion, it is a duty that we carry and the honor of our profession. Thank you.